few disclosures, but nothing of conflict for this meeting. Our objectives today is to really understand a little bit on the historical perspectives of MS, because it does apply to even modern day in terms of assessing and evaluation patients, and also understand some of the newer objective measures for the diagnosis of multiple sclerosis. And then, of course, we will review current and past FDA-approved therapies. And then also some management ideas for multiple sclerosis regarding common symptoms and concerns that you're going to see with your patients in primary care. So I do like this case history, this profile of a female, and I'll just emphasize a few points on her clinical presentation at the time. So Saint Lidvina, she had violent pains in her teeth, and I think you can speculate what that could be, not dental related. Hemifacial paresis, vision change, is that possible? Inflammation of the optic nerve, disequilibrium, paraparesis, ataxia, and then remissions that were attributed to miracles. So going back to the 14th century, we had miracles as a apparent fix for what appears to be multiple sclerosis. She was later canonized, perhaps due to these remissions attributing. So what we have next is a very detailed journal, so-called The Disappointed Man. He was the grandson of King George III, very detailed, meticulous journaling. And he does describe advancement and progressive MS at that. As you can, if you can read a few of his clinical presentation notes here, limb weakness, and it essentially did progress to the point that he was wheelchair bound. And in fact, I think this wheelchair is in one of the museums in England currently. And at that time, current treatment, not just for MS, but for many maladies, was leeches. So now we're looking into the 18th and 19th century treatment for MS, leech therapy. Now we move into a little bit more modern medicine. And so the French pathologist first described this. I'm not going to try to pronounce his name. You can read it. He described a peculiar disease state in 1835. And now this is also published in text that we can reference still today. And looking at the brain and spinal cord, seeing these peculiar lesions. And then, of course, the father of neurology, Dr. Charcot, followed through with this and actually worked with this pathologist, identifying the clinical applications of what these lesions could be. And he was to really describe and coin the term multiple sclerosis. And so this really evolved in the late 19th century, and thanks to Dr. Charcot and those that followed. And of course, William Osler, who's considered I believe the father of medicine in general, but he diagnosed 3 cases of multiple sclerosis once Dr. Charcot published these findings. Classic painting, you have all seen probably many times. Dr. Charcot there in the middle, and speculating even Dr. Freud in the background. Of course, you have many other neurologists that I'm a descendant of, somehow one way or the other. Seems in neurology academia, we take pride in our ancestry, academic ancestry. So you're very familiar with, I believe, the demographics of multiple sclerosis. It certainly seems to be more common in women than men, close to about a 3-to-1 ratio for some reason. It can be assessed in any ages, but the predominance is going to be young adulthood. The youngest I've diagnosed in my clinic is 14. When I was a resident, I saw a 6-year-old kid with MS. And I think the latest age of diagnosis has been about 64. And then we get kind of in that gray territory of vascular versus demyelinating disease we'll talk about. And historically in textbook, we still read more common in northern ancestry of Europeans. It seems to be more common of a certain latitude, like the 45th degree and so forth. This is all getting kind of more and more shaded because we're seeing more evidence of MS in other ethnic groups and closer to the equator. So in terms of the risk, general population, 0.1%. And those with a close relative, 1 out of 40 perhaps at 3% may experience MS. The old, it seemed to be genetically related, interestingly, because of the identical twin variant. But we have many, many genes, HLA-type genes associated, the DR2s predominantly, and another chromosomal. But in terms of the penetrance, it's pretty weak. And so I got interested in this because of my family history. And so from father to son, most data said about a 2% risk, but from female to daughter, transmission, mother to daughter, was close to 10%. So again, more common in females than males anyway, but it seems to have a little bit more penetrance among mothers to daughters. So about 1 million MS people in the United States. We estimate somewhere between 2 and 3 million worldwide, but we really don't know. And we also don't know exactly what causes multiple sclerosis. And this is going to be a continued enigma, I believe, for some time. Just based on multivariable influences, including genetics. But like with many autoimmune diseases, we may have the predisposition genetically, but there could be some kind of culprit or a trigger, which the leading theory right now may be a virus, and specifically Epstein-Barr, and that's getting a lot of attention right now in research. So essentially, you have this trigger that takes place that leads to the cascade of inflammation, which we'll go into detail. And then, of course, demyelination and neurodegeneration. The classic view of this is a chronic progressive demyelinating course. Now we understand it's more than involving the myelin, but the axons of the brain, spinal cord. So again, pro-inflammatory states that likely lead to these early relapses clinically that we're going to see that can progress and facilitate neuronal cell death. And so we're actually involving several components of the immune system. Of course, we focus especially with targeted therapy regarding T cells and B cell production and elimination. And we'll go into this in a little bit more detail. But essentially, the immunoregulation, we expect some depletion and control early stages of immune development, and you're familiar with this. So these cells that are programmed to attack our own tissue antigens should be depleted, wiped out, washed away. But some of these may remain, and this is going along with the theory of maybe genetically. And then you have molecular mimicry as part of this too, where you may have that virus that leads to immune activation involving multiple cells. And then these cells, these bad cells, essentially are programmed to attack myelin and other components, somehow invade the blood-brain barrier. And now, once we're in, we have an attack predominantly on the myelin. And what we see is inflammatory changes, and that's what we're going to see on the MRI. And then we're going to see then neurodegeneration. And we used to think that was kind of a late stage thing. And of course, then we get into the secondary progressive. Well, we have degeneration, probably due to so much inflammation over time. We now know that's probably not true. We likely have neurodegeneration in early course of MS. So essentially, this older model you see here, a breakdown of myelin and eventually a breakdown of the cell body, the axon. Now, of course, MS can involve any domain of the brain and spinal cord. I'm not going to go into the details of symptoms that can be experienced until we get to the more treatment-specific side of things. 4 types of MS, now really down to 3. We kind of narrowed things down. We don't worry too much about if it's progressive relapsing type or so forth. We kind of broke it down to a relapsing form or a progressive form. And within the relapsing form of multiple sclerosis, you may develop secondary progressive MS. And essentially, if you can follow that graph, I guess it's going to be on your right side corner up. What we have is, early on relapses, and about 80% of patients are diagnosed with relapse and remitting multiple sclerosis. About 50% of those will evolve into secondary progressive MS. And as you see in that graph, essentially what that references is this indolent course of progressive problems, notably equilibrium issues, strength issues, and also cognitive, and maybe bladder dysfunction and so forth. So over time, those components gradually get worse and maybe lacking frank relapses, and certainly relapses that go into remission. And the estimated time is highly variable. It could be just a couple years, it could be 10 or 20 years before you see someone progress into that secondary type. Primary progressive, as the name implies, problems right at the onset. You may have a little bit of a relapse that gets a little bit better, but for the most part, we kind of see people go downhill in the sense of their gait and general function, and so it ends up being a progressive course. So, again, early on, we have the visible and invisible components of MS, and notably, there's disease going on that clinically the patients and us may not recognize. But there is something happening underneath. So then more obvious attacks and relapses such as we saw in these two case studies, but notably the common ones, optic neuritis, so they're going to have partial, complete visual loss. They may have episodes of vertigo, and of course equilibrium problems and weakness. It could be hemiparesis, or notably, especially with younger people, it tends to start with sensory complaints. And it can't be just frank hyposthesia, paresthesias, that can be obvious, but it can be also pain. And of course, we see patients and may tend to diagnose fibromyalgia for a lot of these, what could be MS later on, but a lot of these patients get that diagnosis early on, and yes, and we see them in follow-up maybe years later, and sure enough, it looks like MS. Again, some of these subtle subclinical problems that just kind of rear their ugly head at some later point. Now, again, then we get into the secondary components, and I think this slide is just to demonstrate is what science has been showing more recently is that neurodegeneration, axonal loss, acquired early on in the course. Again, long before we see clinical activity associated with MS. So there is evidence of gray matter involvement. We see lesions. The classic approach to imaging that I'll go in just a second, we'll look at white matter. We call it a white matter disease. No longer. Why? Well, white matter is predominantly myelin. And, but we have other cell involvement beyond that. So gray matter, white matter, juxtacortical, spinal cord, posterior fossa, brainstem, so forth. So essentially, we do have still the relapsing, we like to call it relapsing remitting. So we have those categories that we need to use and largely use for research. But we do see brain atrophy over time. And in fact, the atrophy studies are quite interesting. And we see more and more in this in the literature. And so in healthy adults, brain atrophy occurs about 0.15% per year once you get past the age of 30. Which I don't think anybody here is free of brain atrophy, so welcome to the club. Untreated multiple sclerosis, a pretty broad range, and of course we're going to see a high variability, but 0.5 to 1.35% per year. So it's essentially accelerated, maybe even up to 5-fold for these untreated MS patients. So this is quite a relevant issue, especially when you want to talk about preserving brain function, overall general function, keeping them at work and enjoying the things they want to do. What we call neurological reserve, that the brain is finite, so its capacity to retain function by remodeling itself to compensate for loss of nerve cells. So we have that neuroplasticity, that capability of essentially compensating even for our own normal brain, healthy brain cell loss. But with MS, they've compromised their reserve considerably. And so even though we have all these redundant networks to compensate and neuroplasticity, but over time with neurodegeneration, that ability to compensate is weakened. So one analogy I don't use too much anymore, but for a lot of my middle-aged men, I would use the F-150. He may have started off with the F-350, and in time, in a few years, we have to downgrade to a 150, and then you find yourself, I got to get a gremlin. Well, gremlins are not fancy, pretty cars, but, I'm very old, slow, but it's going to get you from point A to B, so there's still some fun. But so essentially our reserves are going to be affected as a consequence to this compromise with the buildup of inflammation and neurodegeneration. So again, a time issue, it's chronic, it's lifelong, progressive, and so obviously we're going to affect function. So the diagnostic criteria certainly evolved over time, and so I'm not going to go into too much detail with the McDonald criteria, but the old Posner criteria, I guess my great-great-grandfather in neurology, came up with a very simple criteria for MS. It's certainly oversimplified, but this predates advancements in technology. But essentially having 2 clinical attacks over time. And time is an element, by the way. Symptomatically, just for your reference, an attack is defined by a neurological episode of at least 24 hours. Why? It can be actually quite vague, but it does make sense in terms of, it's not a TIA. They tend to last for a few minutes, maybe an hour or two. It's not something else that's short-lived problems don't tend to be an inflammatory demyelinating attack of the brain. So we use that 24-hour for a decent representation of what could be an MS flare-up, right? Okay. Now, time, we have to split that up by a month, meaning someone could have several attacks in the first few days or weeks. And it could represent that same lesion that could be expanding, or there's a process going on involving different areas. And we tend to call that a single attack, even though they might have different symptoms, as long as it's within that 1 month period. And then beyond that, we can call it a new attack, even if it's the same problem. Sometimes, and then we have a definition we call pseudo flare-up or a pseudo relapse, which I'm sure you've seen many patients with this. For example, they had an attack that left to right hemiparesis, and it got better. It's mostly better. They feel it when it gets really hot outside, and one time they got the flu and they can barely walk again. Okay, it's probably a pseudo flare-up, right? It may not necessarily represent a new lesion, but sometimes we have to be a little cautious, maybe repeat an MRI. We don't see major changes. Yeah, it's probably a pseudo flare-up. A condition also we call UTOS phenomena. You won't forget that. It's spelled very different than Utah, but UTOS, it just represents that, especially with heat intolerance factors that lead to essentially what appears to be an exacerbation, but likely a pseudo flare-up. So nowadays, McDonald criteria, a little bit more detailed, but utilizing our technology, MRI, utilizing spinal fluid to help in this process for the diagnosis, and it's been modified a couple of times. And so pretty much a standardized criteria to help clinicians, neurologists especially, for the diagnosis of MS. So this does allow for more rapid diagnosis with equivalent or improved specificity or sensitivity, and perhaps with fewer required MRI examinations to clarify, which, now when I first started practice, I utilized spinal fluid quite a bit. And then I think it was McDonald in 2000, I thought it was 11, it was 10 here, changed it so you didn't have to use spinal tap. So I got out of practice, so patients were relieved, I don't need a spinal tap, great, yeah. And then he came out with 2017, and mostly for the interest of clinically isolated syndrome. Now this is maybe a variant or benign or who knows, but maybe an early onset MS presentation where they have a single attack and they may have MRI features that look like demyelinating disease. I'll show you in just a moment. But so it's kind of ambiguous. Maybe pre-MS, maybe nothing, maybe acute encephalomyelitis, so forth, disseminated encephalomyelitis. So McDonald looked at all these papers and patients and so forth, identified, if we look at the spinal fluid and specifically look at oligoclonal banding, immune response, that could kind of give us another point in time. And we can, again, apply Posner's criteria and use spinal fluid. So now I'm going back to doing a lot of spinal taps. And to help, and importantly, to help with the early diagnosis of MS, which when we get into therapeutics, we'll see why. So ancillary testing otherwise, we can use evoked potential and to look at optic nerve demyelinating. We can use other type of somatoform or evoked potentials, and then among other tests, actually. So commonly, though, of course, we're going to have an MRI and utilize this technology. And so we have plaques, white matter changes. Predominantly, it is going to involve these, what we call T2 hyperintensities that we're seeing predominantly within the white matter. And we're looking at all sequences, and we tend to pay attention to flare sequences. It gives us more information in terms of actually calculating volume of lesions, number of lesions, a more clear picture than some of these other sequences. Importantly, though, if you look at the bottom left, the T1 hypointensities that we can see on MRI, kind of hard to see maybe for you, but those little black holes, and that's the technical term, black holes in MS, essentially a representation of T1 hypointensities that likely reflects significant axonal loss and a low chance of repair at that point. And it does correspond clinically fairly well with risk of disability. So I tend to look at 3 sequences on MRI, and I'm focused attention on flare, the T1, and then also the T1 sequence with gadolinium. I'm interested in contrast, and that can tell us if there's enhancement with one of these lesions, that there is a new or active lesion that may correspond with their symptoms, and if it doesn't, that can actually help me with a diagnosis and meeting that criteria for MS. If I see an enhancing lesion that doesn't correspond with this new attack, okay, now we got probably 2 different things going on, even though it's subclinical. Of course, we involve the spinal cord with MS. And then, I think I mentioned the T1, chronic, these black holes that lead to a risk of disability over time as they accumulate. Okay. Early days with MS, we didn't find a correlation with what I call the MRI lesion burden, meaning the volume, the number of lesions, and the relationship with disability of MS. We didn't find that in several papers, not until more recently in Brazil and others. Now we look at more regional involvement on the MRI, not so much the number, but regional. So, yeah, the brain is like real estate. All depends on its value depends on location. So similarly applied, and we look at cortex, of course, in that juxtacortical area, and then we also look at the posterior fossa and everything south. And all of those amount to essentially a less favorable prognosis over time. So in terms of therapeutics, a few remaining minutes, we don't have a cure, but we modulate. We can significantly improve outcomes. And what we have are the old therapies, as I introduced a couple. One was faith, and then we saw leeches. And within this last century, we saw a variety of things listed here, people touted by, and not until 1951, using steroidal therapies, and then later ACTH, and actually seeing remarkable benefit for exacerbations of MS. Since then, he had an array of, especially in the 1990s, well, I think 80s and 70s, we saw bee stings. It wasn't until the turn of the century, goat serum was out there on the market for a cure for MS. And jugular venoplasty, boy, we had physicians doing that. No evidence of benefit, and wasted $18,000. So this is just practice parameters established by the Academy of Neurology, and essentially recommending therapy. And I do recommend initiating therapy early on, because what we're talking about, in stroke and vascular neurology, time is brain. That's a common adage we use to get thrombolytics on board and going, because we're trying to preserve brain tissue with TPA, TNK, so forth. So I see the same way with MS. Time is brain. And I do believe sooner the better. So the sooner we can get these patients evaluated and on treatment, we are preserving brain. There's ample studies demonstrating this. Of course, what we're introducing now are FDA-approved therapies, and largely these, mostly, and especially later studies, 3 criteria have to be met for primary endpoints, including a reduction of relapses, and usually these are within a 3-year period, a 2-year period with studies. They have to demonstrate a change or reduction of MRI changes over time, and that could be the GAD-enhancing lesions, it could be T2 changes, and then also some element of reduction in disability or progression of disability. So the old platform therapies, you're quite familiar with, I'm sure, referred to as interferon therapies, first came out late 80s. And we've seen some changes and kind of Me Too's come out, long after that. And so largely just grouping these into interferon therapy. These are injectables, either muscular or subcutaneous now. And so a list of brands given here. Still used. I still have a few patients on Avonex, for example, a few on Rebif. And so these are patients that are relatively stable, and I'm probably concerned about coming off their therapy, and then I support them along the way. Glatiramer acetate, you may know as Copaxone. It was way back late 90s, the turn, and we saw pivotal data supporting those copolymer. It's just the polypeptide chain. It's pretty remarkable in loops of 4, and seeing this immune change and regulation occur with MS people. It's actually first designed to induce MS in mice. So these mouse models, they were looking for a good MS mouse model, so they used a copolymer A and injected it in mice to give them MS. Well, it didn't really work out that way too well, but they found it was actually beneficial. Just the opposite of what they're trying to do, so it's quite a paradox in research. So various compounds and brands associated with glatiramer acetate. Then we kind of move into the newer generation therapies, pills, oral therapy, which are pretty trendy and maybe high efficacious. What I call the S1P receptor modulators, we have a handful now, these 4 drugs listed here, essentially antagonizing this receptor that leads to sequestering these T cells, B cells, just stay in the lymph nodes and other places, and they don't get out in the system and circulate. So there's a substantial reduction in these inflammatory components. Side effects listed here are common with hepatic issues, notably elevated transaminases, cancer, infectious disease, and pulmonary cardiac issues. Fumarate therapy, we have a handful now. It started with Tecfidera, and now we have a generic and others that are essentially Me Too. Consider around maybe, by the way, I kind of group S1Ps as somewhere between 50 and 60% reduction in relapses. So mentally I'm going, what is high efficacy, what is beneficial? And of course, it's risk benefits, looking at these side effects with every patient. Fumarate therapy, we see close to around 50% reduction in relapses. Associated, though, with lymphocytopenia, we can get flushing and gastrointestinal problems associated. Teriflunomide, it's one of its own, and the mechanism of action with the pyrimidine synthase inhibition. And we can see side effects of hair loss and transaminase elevation as well. About a 30% reduction in relapses overall. Cladribine, also known as Mavenclad, DNA analog, they saw a reduction in relapses over 50%, but associated with potential infections, shingles, for example, in addition to cancer. We don't use mitoxantrone so much. I think I prescribed it once in my career, but an old chemotherapeutic with cardiotoxicity, so less favorable with newer options today. So these are just in regards to infusions, including natalizumab, which is Tysabri, monthly or so infusion. Its risk can be PML, progressive multifocal leukoencephalopathy. So risk mitigation just includes serial testing, specifically for the JC virus, and assessing those titer antibody response to the JC. Lumtrada has gotten out of favor as well. They had some complications. It was pretty a broad spectrum, immunosuppressant in a sense, but targeted monoclonal therapy, CD52, but we saw hemorrhages, strokes, and other vascular problems associated with this. So we've kind of gotten away, and thyroid disease too. I still have to deal with a thyroid problem with one of my patients that had it. So I don't think you'll see that too much more on your medication list, Lumtrada. Alantumazole, ocrelizumab, is one of the newer, what we call B-cell depleters, a CD20 inhibitor. So essentially it leads to B-cell death. The problem with that is when you're getting an infusion, you can get these common infusion reactions. So that's notably one of the bigger concerns in addition to breast cancer seen. Crossover therapy-related PML, meaning they were on some type of other, maybe chemotherapeutic for whatever reason, or maybe Tysabri prior, and then it does place a higher risk of PML when we go on board with something like Ocrevus. Kesimpta, grouped here, but it is a sub-Q, a monthly sub-Q injection, similar compound to Ocrevus, so to avoid the infusion reactions, now we just deal with injection site reactions. But similar compound with similar side effects. Now, these days, we have this goal, what's called NEDA, and I got to wrap this up, but essentially we're looking for no new relapse, no changes on MRI, which is a feasible goal these days with more aggressive therapies. And so as a clinician, that's my goal with patients, to achieve NEDA. And again, looking at other potential therapies. Now, I put these up here because this is what a lot of you are going to be dealing with, and myself as well, but as a cooperative effort to help with fatigue. You're familiar with the stimulants, SSRIs listed here, pain management, as you see here, with generally anticonvulsants, and then other things. Ampera is a medicine to help with mobility, give MS people a little bit more endurance, treatments for spasticity, bladder dysfunction, bowel dysfunction. And then, of course, lifestyle modifications for MS, I think, are very, very important, and this is very trendy, and I think for good reasons. But there is evidence of obesity associated with MS and worsening of MS. Of course, vitamin D deficiency is all over, but very common with MS, and we've actually seen evidence that normalizing vitamin D levels, actually high normal, we're looking at 60 to 100 in studies, showing benefit, reduction in relapses and overall benefit. So that's one in terms of supplemental therapy I'm in big favor of. Of course, activity, University of Utah, with their exercise physiology, has an abundance of studies showing benefit for people with MS. With regular inductive exercise, thermodynamic regulation, meaning just avoid the heat, ice packs, ice vests, and so forth on those hot days. Reduce sodium intake as well. I'm going to leave this cannabis up for just a second. The practice parameters in terms of MS management from the Academy of Neurology, looking at only pharmaceutical-grade cannabis for benefit in spasticity predominantly, and then modest or mild benefit for some other things. No benefit for tremor. But the problem with cannabis is what? The list of side effects here, which mimics MS very well, you can see in the red. And so I do have my reserve in terms of any potential benefit of cannabis for my MS population, although most of them that come and do it swear by it. But do I see these problems listed here? Of course, very, very common. So it doesn't mimic MS very well. So in summary, MS is a lifelong problem. I think it is a cooperative effort among all of us to help manage people with MS, multi-system involvement. So it is a team effort, and all that is very appreciated as we go along. And I do depend on you guys to help with my patients with their MS. And so I'll just leave it there. I don't know, do we have time for questions? All right, thank you.